Welcome back. You're listening to the panel discussion, RX for Federal Healthcare Transformation through IT, sponsored by Infor on federalnewsradio.com and 1500 AM. I'm your host, Jason Miller. My guests today are Colonel William Baez, the Chief Medical Information Officer in the Office of the Air Force Surgeon General, Andrew Jacobs, the Technology Strategy Branch Chief for the Defense Health Agency, Wayne Bobby, the Vice President for Infor Federal, and Beth Myers, the Chief Nurse Executive and Analytics Strategy Director for Infor. The last segment we ended with talking a lot about the data analytics piece, and Beth, you made an interesting comment kind of off camera a little bit about everything's data analytics. And I remember going back to almost 2006, 2005, someone said to me, it's all about the data. And that was like, boom, it was like the epiphany, right? So let's talk a little bit more about data, because it's the great topic. One of the things that we were just talking about is the back office piece. And I think there's a interesting aside to that is, it's not just, hey, do I pay my bills on time, but do the nurses and doctors get the supplies they need on time? So the supply chain. Talk a little bit about what Infor and what your experience is around the supply chain piece regarding data.
Thanks for that intro. I'd love to talk about supply chain because that's how I got my start in data analytics and informatics, actually. I had some surgery in my hand when I was an OR nurse when I was active duty Army, and so I got assigned an extra duty assignment to incorporate Pyxis machines, which are cabinets that are electronic cabinets in the operating room. That was my assignment. And I remember sitting in the office with my Colonel Diamond, and she was very IT savvy at that time for a clinician. And I was talking about how we could connect those components of those supplies and then maybe make them automatically reorder them. And she said, it's even bigger than that. We could connect those supplies back to not just reordering inside the hospital, we could connect the supply directly to the electronic health record, to the pick list, so we know what supplies are going to be used, and extend that supply chain beyond the four walls of the hospital. And the computer system, the IT system, could automatically chart those supplies, reorder the supplies, make sure that we always had that on hand. And as an OR nurse, it's crucial that we have always the right type of supplies on hand. So
we're using like RFID tags or what? Because how do you, I'm not sure how long ago, if this was 5 years ago or 10 years ago or longer, the technology wasn't there to do this. So how did you make the connection?
It's part of a manual process at that time, and those cabinets are still being used. They're electronic cabinets where you push a button when you take that supply out, and you can match that supply directly to the patient's name when you take it out of the cabinet. Okay. So today that is being done more frequently with RFID, and so eventually, and in my ideal world, we'd be able to automate it completely, because a nurse shouldn't be worried about documenting what supply goes to which patient. They should be busy holding that patient's hand while they're going to sleep for an important surgery.
Interesting. Andrew, let me turn to you, because you guys also have to worry about the supply chain piece, but it's maybe more on the logistics side.
Yeah, so from our supply chain perspective, that's extremely important. So all of her examples are good examples, and to kind of add on to that, in the older days, that also could have been more weight part of it too, so it actually knows what the weight is, and when something's removed, it knows something was taken out. So it can, key in what you're inventorying and what you're not inventorying. So it's not just in the older days RFID, but that's the preferable way to kind of do it now. It's extremely important for us, the supply chain, and keeping it up, and not only just for Garrison, but also more in that theater perspective also, to make sure we get the right supplies to the right people at the right time for the right care that needs to be delivered. One of the things we also need to look at, and this incorporates in that big data analytics, is actually being able to kind of load balance that, in the sense that if this hospital doesn't use as many IV bags as this hospital, and they're running through them, so like at Camp Pendleton with the Marines, during the middle of the summer, and they're pushing a lot of troops and doing a lot of things there, before these IVs expire, why don't you send them there so they can get used? And we don't have to actually waste a lot of money on expiring IVs or expiring drugs or anything. But being able to kind of load balance those across our whole enterprise and get them there, so we're actually not spending more money by destroying these things, but we're actually getting use out of them by getting them to where they're actually going to be used.
How often is that happening, and is it done automatically? Meaning, one of my favorite TV shows is MASH, right, from the 70s, and they would always an episode every season about somebody calling up looking for supplies. We need plasma. What can you trade? So that was all done by manual, right? I imagine that's not, Camp Pendleton's not calling Lackland Air Force Base going, hey, you got any IV bags you can give us? Is that being done automatically? Or Beth say maybe it is. Max was real, you see.
I'm not too sure everything is automagic right now.
Automatic.
I do know there are some efforts to actually point it in that direction, but you really need a good integrated system and that backside actually feeding the electronic health record and everything. You know, that's kind of where we're trying to get with the whole MHS Genesis, is to get these fully integrated systems that are going to allow us to actually have what I said in the other segment, that active architecture, to actually act on that information in a very proactive perspective.
Interesting. Wayne, does such a system exist where you can be proactive and understand when something runs out to reorder it?
Well, they do, and I was going to share an example. We started to talk offline here about what Infor is going to do at the National Institutes of Health, the hospital there. So, picture, if you will, when the UPS truck backs up to the loading dock at the NIH hospital, they'll unload those boxes based on orders that have been calculated based on requirements and patient needs, and those items go into inventory at the hospital. They go and they get scanned or RFID tagged to make sure that we know what's now in inventory. And then you use that to do just in time, putting together those surgical kits for the surgeons, for the doctors each day. That complete supply chain at NIH is being managed by Infor Supply Chain today. And there are countless examples of that across the commercial, the commercial world today that need to be brought in. Now, you take that to the military side, where you have folks, you have people in theater, you have a completely new set of requirements and demands. You're looking to get immunizations to people all around the world. All of a sudden, you raise it up a level, of course, but those types of tools are in demand today and are available today, yes.
I think it's a great example of saying as soon as it comes off the delivery truck, they know what they have, they know where it goes, they know where it is. So if you say, as Beth's example was, the OR nurse was making sure that they have all the supplies they need, they don't have to worry about that. If we're missing rubber gloves, let's use an example, they know how many they have and where to find them, I imagine, right?
Exactly.
Yeah.
Exactly. Yeah.
And what is why it seems so logical? So why is it so hard to get there, right? What is it? Just a culture thing? Every time we talk tech,
it's a cultural thing. It's a lot of how things have been done in the past. A lot of disjointed systems, where they don't talk to each other. Everybody has their own stovepipes. It's a overused term, but of course it still exists. Stovepipes, where now you've got. Hospitals don't talk to each other. So why am I sitting here at this hospital or this clinic where I have an overabundance of this supply, but one right down the street, they're ordering mine more, when you might say, well, why don't you just go get some of those, have those shared from that other hospital unit, and then make sure that you guys are being much more smarter about your ordering going forward. So the other side of the supply chain is not just ordering to meet your demand, but also make sure you don't abuse it by over ordering and spending money, because that increases the cost of care. So,
Beth, jump in.
And the other component of that is making sure that we can standardize care, because if they're doing a different treatment at every hospital, because we're based totally on expertise, we require a different supply for every physician, as opposed to standardizing to the best care for all those patients. And I think Colonel Baez had some.
Colonel Baez, jump in too.
Well, and I agree with you on that point. We've certainly done a lot in the area of standardization, trying to get to where, we reduce the supply requirement. But for us, it's compounded when you talk about overseas bases and having to deal with local national laws about bringing in certain materials. And some places it's easier to get stuff than others, and our folks have to manage that. And I bring that up because until we have the automagical solution, I like how you said that, we're still relying on those airmen or military members to be that sensory, that alert person to let the rest of the organization know, I've got an issue here, or I think that what I don't have or what I'm having trouble getting may affect patient care. And I brought that up because we did really well in a study last year on patient safety when it talked. The study looked at near-miss reporting and just in general the reporting culture throughout the organization, and the Air Force was able to have a much higher number of reports throughout the year. And I think it's a testament to the culture of airmen not being afraid to say, you know, this thing almost happened that could have harmed the patient, but I did this to prevent that from happening. And I'm not saying that to say that we've got a lot of mistakes to recover from, but instead, I think what's really important is that you've got healthcare teams that are looking at every aspect of healthcare, and they're trying to figure out how does this affect, you know, this bigger mission that I'm in, and how does this affect the patient's health. And I like that because the culture spread from the clinic, which it's pretty easy to kind of generate that in the clinic, to the back offices where folks that in the past haven't really worried about that so much are now thinking about how does me not having this particular supply perhaps impact a patient if I'm in, for instance, Korea where I was stationed before.
Yeah. I think it's an interesting point that the long view is what's happening. When we talk, Andrew, you talked about the long view of technology. Well, technology helps you understand the long view of patient care, and I think that's what Colonel Baez, you're kind of getting to, is ensuring that the quality of care is there based on not just the technology side, but the people side, right? The
Right.
person who says, "Hey, I could do this better," and you can learn from my almost mistake or my mistake.
Yeah, everybody, and that was the point, is we're seeing it more and more that everybody on the healthcare team has an opportunity to improve healthcare. Right. And so I like that versus the old, 20 years ago, it's whatever the doctor said or perhaps what the nurse said, and the other folks are just ancillary support. And that is not the way we're doing it now. We see an opportunity to learn from every one of those folks that are in the healthcare chain.
You bring up a good point, the future and opportunity, right? So as we look, we've had a great conversation, and unfortunately we're almost out of time. But as we go forward now, I'm going to start on this side of the table with Beth, since we started on that side of the table last time. What are we looking at future? If we have this conversation again in 3 to 5 years, what's the future of health IT, healthcare technology look like?
Well, I will be finished with my PhD.
Hopefully.
In 3 to 5 years, that's my new goal. And in that PhD, I'm studying the expertise and decision making and how those decisions are impacted today and how they could be impacted better by technology in the future. And I think that incorporating evidence-based decision making into our clinical practices and our operations practices across the organizations is that future for 3 to 5 years. You'll see us leveraging those 3,000 technologies or the 400 to 500,000 technologies that are out there, and better ways to help those experts make decisions and relieve the burden from documentation from the clinicians.
All right, Andrew.
So the two things I might talk about is I would see much more data analytics starting to get solidified with more data standardization on what kind of archetypes there would be for the data, so they integrate more into the open source platforms, because I see a lot of open source actually taking over versus more silo-based type big monolithic systems. The other part of that would be the telehealth, especially from our perspective.
E-health, we renamed it, right?
So from our perspective, we look at it as virtual health,
Yeah.
because it's not, you're exactly right, it's not just kind of that visit, it could also be the educational part of it, as Colonel Baez had talked about. We have a program called ECHO, which is a lot of telementoring.
Yeah.
That's a telementoring. So those are the two things, especially from our perspective, I think is going to take off a lot.
All right, Wayne, jump in.
I think that transparency is going to become even more of an issue. We saw it just recently in the presidential debates in terms of these stories about the veteran who couldn't get an appointment or was turned away or took a number of months. I think that with the analytics and with the internet now, all this information is surfacing much quicker. So I think that so the analytics are coming along. I think that they're serving us much better, but I think that and the transparency is going to help drive, finding these answers, finding these results, increasing the level of care and improving the cost of care as we draw more attention to the problems.
All right, and Colonel Baez, take us home. You have the last word.
So I'd like to emphasize that everything we do has a focus on readiness, and I see in the next 3 to 5 years, we're just going to keep a laser focus on how to maintain readiness with our teams. And so I see collaborations as becoming more and more important. We currently benefit from collaborations with civilian hospitals like the Baltimore's R. Adams Colley, the Shock Trauma Center, and the University of Cincinnati, St. Louis University, University of California, Davis, University of Nevada, and University of Alabama, Birmingham, to name some, where our medics are going into those hospitals to get the training they need so that they can see the more complex cases that perhaps they don't get to see in some of our military institutions. And part of that's because we try to maintain a nice, healthy force. But in the moment of a trauma or a conflict, you want somebody that has had the opportunity to do those kind of things. And so I think in the future, growing those partnerships, having more opportunities to collaborate will help us keep our physicians ready whenever they need to fight tonight.
All right, well, excellent. Thank you all very much. Unfortunately, we are out of time. You've been listening to the panel discussion, RX for Federal Healthcare Transformation through IT, sponsored by Infor on federalnewsradio.com and 1500 AM. I've been your host, Jason Miller. I'd like to thank my guests. For more on this discussion, visit federalnewsradio.com and search Infor.
On behalf of Infor, thank you for joining us. A link to the archive session will be sent to you shortly. If you're requesting a training certificate, you will also receive an email with download instructions after the webinar. This concludes our discussion. Thank you.